minimally invasive. When people think of glaucoma, they think of blindness, so my answer already is, you will not go blind if you are proactive. And the second thing is, if you know people who've had glaucoma surgeries, most likely you will know and have heard of more of complications, of devastating outcomes. But the good thing is, now that we have microengineering, that we have very refined instruments, and that we are working on microscopic scales of this drainage system and not just poking a hole in the eye anymore, like trabeculectomies, we are able to do these surgeries in 3 minutes, and the complications are very low. We can improve vision at the same time. We can remove cataract. So glaucoma surgery has changed, and the good news is, if you are proactive, you will prevent a lot of harm. You can address the cause of the outflow failure. And apparently, these procedures last long. We now have a body of 7-year data, and that looks fairly promising.
You mentioned cataracts. So do glaucoma and cataracts kind of come as a pair?
They do come in a pair. And directly, they don't necessarily have anything to do with each other, but they do occur in the same population. And I find it very important to improve vision function, because that's what matters for patients. It is not the pressure. Is the pressure 15 today? Is it 13? Hooray, it's only 12. What really matters at the end of the day is the function. How are patients able to go around? Can they see well? And the cataract is a big factor in that. It occurs in the same population. And as I mentioned, these newer minimally invasive surgeries that we offer here at UPMC, trabectome, the eye stand, just introduced now. We're one of the few centers with the largest experience of these minimally invasive surgeries. You can easily have cataract procedures in the same session and improve vision and improve quality of life.
That's great. I'd like to open it up for questions from the audience. And so, questions for Dr. Lowen? Any questions on glaucoma, cataract? Totally filled everybody in on glaucoma and cataract, which, yes?
About cataracts, what I don't understand, why it can be good one day and the next day it's not. I didn't wear glasses up to now, I'm 83, but now I have cataracts. I went to the physician and he said, if I had your eyes when I'm as old as you are, I would be real happy. The next day I could hardly read anything. And then 2 days later it's okay again. So that's what I don't understand.
That sounds very interesting, but most likely what you're describing are more surface problems of the eye, meaning a dry eye. That can fluctuate greatly. So one day when you're in an air-conditioned room with low humidity, you're looking through something that's maybe similar to a dusty windshield with a lot of light scatter, and your vision seems worse. And maybe you think that's your cataract. But the cataract cannot be better one day and worse the other day. That has to be a surface problem, most likely. And for that, oftentimes we just start artificial tears, but we can also allow yourself to keep your own tears longer by putting in little plugs, so you have your own tears longer. So that's very treatable, what you're describing.
All right, well, let's thank Dr. Lowen. Thank you very much for this. And finally, I'd like to change things up a little bit and invite someone who joined us just 2 years ago, Ken Nischel. And Ken is the chief of the Department of Pediatric Ophthalmology and Strabismus. He is the head of this service at Children's Hospital and also at the Eye and Ear Institute. I left out adult motility, I'm sorry. And he got his MD from King's College Medical School at University of London, completed his residency at Oxford, then Birmingham Eye Hospital and King's College Hospital, and did a fellowship in Toronto at Hospital for Sick Kids. He has authored 18 book chapters and over 100 peer-reviewed scientific articles. He's also written 3 textbooks, and he co-founded the World Society of Pediatric Ophthalmology and Strabismus. Please welcome Ken Nischel.
I think it's on.
So Ken, welcome.
Thank you.
And I didn't mention, actually, that you were running the pediatric ophthalmology service at Great Ormond Street
I was.
in London, the premier pediatric ophthalmology service in London. How would you say that the health system that you see differs between here and back in London?
That's a difficult and an interesting question. Look, the one thing that struck me when I came to the United States is that when I prescribe a drug for a child, I don't know if the parents are going to be able to afford it. And I wasn't used to that. I would prescribe a drug that I felt was very important to save the sight of a child. For example, with glaucoma, unfortunately, children can get glaucoma as well as adults, and it's a little bit more severe in children because it's more acute. It's damaging not only their optic nerves, but their brain, and I'll come to that in a minute. So I would prescribe this drug and ask to see them in 2 months, and the parents would come back and say, the insurance declined it, and I couldn't afford it. I wasn't used to that. In the United Kingdom, when you prescribe a drug for a child, it's free. Now, Children's Hospital have a great scheme where there's a fund for children who live within the greater Pittsburgh area and also parts of Western Pennsylvania. And if you live there and you don't have the money, you can apply for that fund. But not everybody knows about it. And if the parent doesn't know about it, then the child won't get the drug. So that was, if you like, the downside. The upside is that there is access to care if you need it. In other words, in parts of the United Kingdom, not every child would get the same standard of care. So if you are in a certain part of the United Kingdom, there's a chance that you may not get the same standard of care than if you were in London. Where I haven't seen that here in Western Pennsylvania or anywhere in the United States. The access to care and the standard of care is really very good in all of the centers. Obviously the best in Pittsburgh, but the point is that there is an access for care. And what we need to do is we need to work out a way to make sure that at least children have access to pharmaceuticals. But that brings me to another point, a very interesting point. In the United Kingdom, Tobradex, which is an eye ointment, costs £12. That's $18. In the United States, it costs $120. One tube. And you know why? Because the pharmaceutical companies sell to a nationalized or socialized health service in bulk. And when they do that, in order not to lose the order, these American companies, they slash the prices. They sell it at a loss. And who picks up the buck? The American citizen, the American population. They pick up the buck for nationalized medicine in other parts of the world. It's a fact. And we can't do anything about it. I can't, as a doctor, turn around and say, I am not prescribing this anymore until you bring the price down, because I will get sued.
So these are very difficult problems.
They are.
What brought you from London to the United States?
Well, it goes back to that question of, well, firstly, the level, the standard of care, no matter where you go, is very good. But I was working in a superb place, Great Ormond Street Hospital Children, the oldest children's hospital in the English-speaking world. James Barrie, I don't know if you've heard of James Barrie, he wrote Peter Pan. He bequeathed Peter Pan to Great Ormond Street. It is the only copyright in the world that exists in perpetuity. Every time somebody says Peter Pan, Great Ormond Street gets some money. It's a very rich hospital. So the question is why did I leave that, especially since I was the head, to come here? The answer is a paradigm shift. Many of you have heard Joel Schumann talk to us tonight. What you don't know is that Joel Schumann, or perhaps you do, was involved in a paradigm shift. He changed the way people think about retina by creating a machine with a group of people that allows you to look at that machine, look at the retina in a way that we couldn't look at it before, right, Tom? That was a paradigm shift. It was a change in the way we looked at a certain problem. What's interesting is that paradigm shifts in ophthalmology don't usually occur with academics. The first man to put an implant in an eye after cataract surgery was not an academic. He was a private practitioner in Harley Street. How many people have heard of Harley Street in London? It's the street of shame. It's where all the medical doctors on the NHS go and do their private practice. I have a practice there, or at least did. The point is that Harold Ridley invented the implant and changed our lives. But he was not an academic. And that's not unusual. The man who invented phacoemulsification, the way we take cataracts out now is so much better than it used to be 10, 15, 20 years ago. Now you can do the whole operation in about 8 minutes, and you're out, all done. You don't have to lie down, have your eyes padded. And it was because of phacoemulsification. Charles Kellman, a private practitioner. So it's unusual to have an academic who's involved in a paradigm shift. And part of the attraction was the fact that what you've created here and helped us create was, I saw, as a foundation for some of the paradigm shifts that I want to create and have created in pediatric ophthalmology. So I know you're the chair, and I'm not saying you're the reason why I came here, please.
Come on.
But what I'm saying is that when I visited Pittsburgh and I met the people who were here, and I could see the group beginning to develop. You know, you have Bob Hendricks, who's world-renowned on herpes simplex virus. At that time, we didn't have Igor and we didn't have Niels, but Tom was here, Andy Eller was here, Deep Dhaliwal was here. These are amazing individuals, and I saw an opportunity here to bring what I had to offer and make my life and my professional contribution much easier. You know, they say that before the moment of creation, you have to have a leap of faith. When there is nothing and then you create something, what's the gap between? It's a leap of faith. And there are many of you in the audience, fantastic people, who've helped individuals at UPMC Eye Center with that leap of faith, with your generosity. But you had a leap of faith. And it's very important that you work with people who have that same faith. And that's why I came to Pittsburgh. I have to tell you, I winked at Niels because he said, there's no way you can say a good reason why you came from London to Pittsburgh.
Actually, the last thing I wanted to ask you about was the World Society. And you created this International Society for Pediatric Ophthalmology and Strabismus. You're obviously involved in international ophthalmology at many levels. Why was it important for you to create this entity?
So there were three really important reasons. One was I've been very lucky that I've been invited around the world to speak about the things that I do. One of them being corneal transplants in babies. Unfortunately, babies sometimes are born with corneas, which are the window of the eyes, that are not formed. And so in order for them to see, you have to do a transplant. And in many of these talks, I'd go around and I would see people who had amazing expertise in their particular country, but didn't have the resources that I had. And so they thought, because I was from the UK, because I had that accent that makes you think that no matter what I say, I know what I'm talking about, they looked up to me when actually their expertise was better than I was, but they didn't have the resources. So the first reason was that we wanted to show that expertise did not reside in one part of the world. There were people who had something to offer to all of us as an exchange. The second reason was, and this is a really important reason. Tom, you talked about getting 5,000 people in the ARED study, right? How long did that take?
It took a couple of years.
Right. Imagine if we had 25 centers around the world that were bona fide, were part of a IRB run by Pitt that had clinical governance and research governance at each center, where you were able to do telemedicine meetings and conferences and evaluations. How quickly could we have reached that 5,000? In 6 months, right? Especially if the populations are large. So that was the second reason, is that we want to be able to get answers for blind children quickly. The bigger the number, and as long as you have clinical governance and research governance, you can do that. The last reason was that when people meet and become friends, they often do great research and great clinical work. And while this idea of 25 centers may sound like pie in the sky, Joel, you know that as of yesterday, University of Pittsburgh is involved in the first international program to deliver genetic education to 10 ophthalmic centers all over India. It's never been done before, and we rolled that out yesterday through your networks and my networks, and that's precisely why I set up the World Society with David Granite.
That's great, and I think that that's poised to make a tremendous difference in a country with a billion people.
And why are we doing that? Because we need genetics understanding on a large scale to answer the very questions that everybody's asked tonight. Why does glaucoma damage us? Why do we get age-related macular degeneration? Well, there must be genes that predispose us to these things. But if we keep looking at 1,000 patients or 500 patients, it's not a big enough sample. We need to look at 250,000. We need to look at 500,000. But we can only do that if we have centers engaged around the world with Pitt.
And it's not only that billion people, right?
No.
It's the whole world.
It's the whole world. It's the whole world. China, India, Africa. And remember, these populations are part of our American society. Mm-hmm. You know, if we're going to deliver care to every citizen, we need to know their ethnic background and the genetic makeup. That's what personalized medicine is about. And that's what Pitt's really at the forefront of. And that's another reason why I was keen to come here.
Great. Thank you very much. Let me throw the floor open for questions. Yes, please.
One of the phenomena you hear an awful lot about today, which is going to affect many fields, is 3D printing. And that's where you can build up 3D objects inside of a printer, which intrigues me with the possibilities of maybe replacement parts for lots of things, including people and perhaps even their eyes. Is there any of that kind of thing being investigated at this point in time, or is it too soon?
I think we're not at the point where we can simply print things elsewhere for eye care, but we are at a point where we can do telemedicine and diagnose and treat remotely. Actually, UPMC and here in ophthalmology, we're one of the leaders for tele-ophthalmology, where we're trying to reach out to remote, for instance, emergency rooms at this point, and help with the diagnosis making and the decision making. Is something urgent? Is it not urgent? Does this patient have to go on this arduous trip to come to Pittsburgh, or can they be seeing me the next day or in a couple of days, for instance? So at this point, only diagnosis making and maybe treatment, but not actually doing surgery or providing replacement parts remotely. But it's probably going to be there pretty soon.
So you got that electronic health record?
Yes,
there,
I got
right?
it in.
Yeah. So we do use 3D printing for research, and so it's great for rapid prototyping. If we need to have some custom part, or we have an idea and we want to see what it's going to look like in 3 dimensions, We have great facilities for that sort of work. But in terms of using it clinically at this point, not happening. In terms of using it to print organs, it's happening in the research world. Yep. So it's a great question. And it's, right at the threshold of where we are right now. Other questions? Questions for Ken? Or any of us? We're obviously between everybody and the food. I want to thank you all for coming here. Thank you very much. Thanks to our panel. And thanks especially to Vice Soffer.